Nerve injury is probably the one thing that we all worry about whenever we perform regional anesthesia. Having a realistic idea of this risk is important. It helps us decide if we should offer a block, if the potential benefit outweighs any risk. It also allows us to provide proper informed consent and to educate the patient on what to expect. Most estimates of the risk of postoperative neurological symptoms after regional anesthesia come from retrospective studies of large databases. Prospective studies looking specifically at this risk are almost impossible because of the relative rarity of these events. These are the estimates quoted in this excellent review article, which in turn come from the 2015 ASRA Practice Advisory on Neurological Complications after regional anesthesia. This 2022 paper from Albom and colleagues addresses this knowledge gap with an interesting study design. They pooled all randomized controlled trials that assess for reported postoperative neurological symptoms. They confined their search to adult patients who receive any upper limb block for upper limb surgery in the period from January 2008 to August 2019. This was chosen to encapsulate the area of ultrasound guidance, but they did not specifically exclude non-ultrasound guided techniques. They found 143 randomized controlled trials that met their inclusion criteria, and these involved over 12,500 patients. Interscalene blocks were by far and away the most commonly represented. Ultrasound guidance was used in 71% of patients, and 86% of the blocks were single shots versus 11% of catheters. For the purposes of this review, they defined the following follow-up periods, and the primary outcome was the aggregate risk of any new postoperative neurological sign, symptom, or dysfunction occurring at any time after peripheral nerve blockade in upper limb surgery. So this definition is a very broad one. There is no differentiation based on type, severity, or duration, and this must be borne in mind when we consider the clinical significance of their findings. What they found was that in patients undergoing any type of upper limb block for any type of upper limb surgery, 6 to 8% experienced some form of postoperative neurological symptoms. This translates into roughly 1 in 16 patients if we take their optimistic estimate. When they looked at the incidence of postoperative neurological symptoms by block type, the highest risk was with interscalene blocks, with 11 to 13% of patients having some form of neurological symptoms, which translates roughly into 1 into 9 patients. And you can compare this with the rates of about 4% that were calculated for the other brachial plexus blocks. The good news here is that most of the deficits were temporary. By my calculation, there were only 10 definite cases of persistent postoperative neurological symptoms at more than 3 months, or about 1 in 1,200 patients. And if you read the paper, you'll see that Albom and colleagues were a little bit more pessimistic in the estimate because they included an additional 21 cases that were reported to resolve anywhere between 1 to 14 weeks after surgery. Another piece of good news is that most of the deficits were sensory. The interscalene block still comes off worse in this comparison, however, which leads me to my next point, which is that the cause of the postoperative neurological symptoms in Albom's study is unclear. The risk of neurological symptoms is the risk that followed not just peripheral nerve blockade, but peripheral nerve blockade and upper limb surgery. And it turns out that there is a significant rate of surgical nerve damage in upper limb surgery. In one study of total shoulder arthroplasty from Johns Hopkins, there was a 16% incidence of postoperative neurological symptoms that lasted more than 48 hours. Note that this specifically excluded transient symptoms following an interscalene block, which they termed nerve block related. What about non-shoulder surgery? Well, this article used a very similar methodology to Albom, pooling randomized controlled trials, but they had a little bit more restrictive definition of postoperative neurological symptoms, categorizing them as either peripheral nerve injuries, which are symptoms that persisted more than 30 days after surgery, or transient paresthesias that resolve within 24 hours. They also included only studies that use ultrasound-guided blocks. The incidence of persistent neurological deficits lasting more than 30 days was 0.5% in shoulder surgery and 1.4% in hand surgery, for an overall incidence of 1.1%. The transient paresthesia rate by comparison was 6.8% in shoulders and 9.4% in hand surgery cases, for an overall incidence of 8.9%. This is closer to the rate observed by Albom and colleagues, which suggests that while postoperative neurological symptoms may indeed be more common than we believe, the vast majority are going to be transient and not clinically significant. So what should we do with this? Stop doing blocks? I don't think that's the right approach. The key, as I see it, is risk management and risk mitigation. Make sure you choose your patients carefully and consider the surgical operation that is being undertaken. Counsel your patients to expect sensory symptoms for up to 48 hours. This is going to be common. And recognize that in many cases, we as anesthesiologists are unlikely to be responsible for prolonged neurological symptoms. Surgical and other perioperative factors play an important role. Nevertheless, at the same time, I think we have a responsibility to maximize safe block performance. And there are two things within our control here: mechanical trauma from needle nerve contact and chemotoxicity from the injectate. How do we minimize the risk from mechanical trauma? The most important thing is to develop good needling technique, something I have discussed extensively elsewhere. Practice being meticulous each and every time you do a block and not just during the high-stakes ones. Refrain from being too fancy or aggressive with needle redirection and manipulation. There's often a temptation to get super close to visible nerves and to surround them with local anesthetic. Don't touch nerves with your needle if you can help it. Utilize the fluid jet instead. Aim to enter and fill paraneural compartments, but don't chase after circumferential spread, because donuts are not essential to efficacy. It's also important to choose or design safer techniques if these are available to you. For example, I prefer the superior trunk block over the interscalene block because the trunk is more protected by connective tissue than the cervical nerve roots. Similarly, I prefer the infraclavicular block because the compartments are more well-defined and easier to enter compared to intertruncal planes in the supraclavicular area. But that's my personal opinion and preference. You should always perform the technique that you are most comfortable with in that particular instance. As for chemotoxicity, all we can do is minimize the volume and dose of local anesthetic that we inject, recognizing that local anesthetics are neurotoxic in themselves. This again leads back to the importance of good technique and striking that balance between being accurate but not aggressive. Finally, follow up your patients, reassure them appropriately, but also have a system in place to investigate and manage more serious deficits. Try to avoid any blame games because the cause is of secondary importance. Instead, ask yourself what you can do better next time and collaborate with your surgeon. Prioritize supporting the patient and preventing any progression or secondary injury from the neurological symptoms.